we're learning. So
Sounds very important.
yeah. So today we are very interested to have Greg. Greg, like most of us know him very well. He is a true Californian. He go to medical school there, get residency training there, got general surgical pathology and pulmonary pathology fellowship there. Then after that, he decided to go to North a little bit, just for 1 year, I guess, for the our beloved cardiovascular pathology. And then he go back immediately and leading both cardiovascular pathology and autopsy, serve as chief of both services. He is currently associate professor and have a very impressive publication record. Last time I checked, is about 100, right?
Maybe not that many.
Yeah, at least 73.
Okay.
So, yeah. So now today his research interest in heart and lung transplantation and medical device. So the paper he's discussed today combine all this experience very well and will cause some controversy, I believe. Greg, please.
Yeah, thank you very much, and thanks everybody for joining me. So yeah, the paper I thought I would speak about is the international experience of in situ recovery of the DCD heart, a multi-center retrospective observational study. I have no financial disclosures. And I'm just going to start with a very basic introduction. We all know heart transplantation is a very effective treatment for end-stage heart failure and dramatically improves prognosis and quality of life. But one of the main limitations is donor availability, and there's a tremendous imbalance in supply and demand when it comes to donor hearts. Organ donation after brain death, DBD, has been the norm in heart transplantation. I'm going to refer to that as DBD. But donation after circulatory death, DCD, has the potential to increase the size of the donor pool and decrease waitlist mortality. So I'll talk about what does it mean, DCD. Most hearts are recovered from donors who are confirmed to be dead using neurologic criteria. This is the DBD donation after brain death. DCD donation occurs after withdrawal of life support in donors who do not meet criteria for brain death. Death is confirmed after complete absence of circulation and respiration for 5 minutes. And this time is chosen because no patient has spontaneously recovered circulation after 5 minutes. And then the ischemic DCD hearts are reperfused. And this can happen ex situ, outside the donor's body, or in situ, inside the donor's body. And it's estimated that using DCD will increase the donor pool by up to 30% if widely adopted. One of the ways that you can use the hearts in DCD is by direct procurement and preservation. And I'm going to walk through what that means. So life-sustaining measures are withdrawn. So these are patients who consent to donation. Life-sustaining measures are withdrawn, and they're allowed to expire naturally. After that 5-minute hands-off period, circulatory death is declared. The chest is opened, the heart is removed, and what they call organ care system, the heart in the box, is used to reperfuse the heart and restart the heart outside the body, ex situ. It's then assessed for suitability for transplantation in the box. And transplanted, it's kept perfused in the box and beating in the box while it's transported to the recipient. What I'm going to talk about today, normothermic regional perfusion, is different. This is how it works. Life-sustaining measures are withdrawn. There's the 5-minute hands-off period, and circulatory death is declared. A median sternotomy is performed, and systemic arterial and venous systems are cannulated for ECMO. The aortic arch arteries are occluded. Thoracic and abdominal organs are reperfused in situ using ECMO. The suitability for transplant is assessed in situ. And if deemed suitable, the heart is removed and transported either on ice, cold storage, or mounted in an OCS box which is referred to in the paper as ex situ machine perfusion. So ESMP, ex situ machine perfusion. What are the benefits of NRP over direct procurement? Reduced warm ischemic time. It actually takes longer to mount a DCD heart to a perfusion machine than it does to return circulation in situ. And the perfused beating hearts can be assessed in situ using transesophageal echo. The cost is much lower. The OCS console, according to the paper, it costs $400,000, but I found a cheaper one on Amazon for $275,000. Different reports have varied, but that's pretty much the range. There's also maintenance costs. A single donor run uses about $38,000 to $75,000 worth of single-use components, whereas doing the ECMO cannulation in NRP raises the cost by only $4,000 for each heart assessed. The other thing is that 17% of the DPP hearts will be turned down after perfusion in the heart in the box, and that costs about $100,000 each. Whereas because the NRP hearts are assessed in situ before they're procured, 100%, and this has been validated in studies, 100% of hearts procured with NRP are accepted for transplantation. So moving on to the study, the study objective was to assess the mid-long-term clinical outcomes of DCD donor hearts recovered and transplanted from donors undergoing thoracoabdominal NRP. And a subgroup analysis comparing hearts preserved on ice versus ESMP was also performed. The study design, this was a retrospective international multi-center observational study involving 15 major transplant centers, 3 in the US, 1 in the UK, 2 in Belgium, and 9 in Spain. Patients were enrolled and followed up between February 2nd, 2015 and July 29th, 2022. The pre-op parameters they looked at were donor age, donor height, donor weight, donor ejection fraction, recipient age, degree of pharmacologic support. Intra-op parameters were the times from withdrawal of life support to reperfusion, withdrawal of life support to functional warm ischemic time to reperfusion, recipient pulmonary vascular resistance, and cold ischemic time. And then the post-op parameters were the use of mechanical circulatory support, survival, of course, hours on the ventilator, length of stays in the ICU and hospital, acute rejection warranting treatment, and incidence of cardiac allograft vasculopathy, RV and LV function, and the number of other organs transplanted. They also compared outcomes between hearts preserved with cold storage and ex situ mechanical perfusion. In the US, Belgium, and Spain, all DCD hearts were recovered using NRP per the hospital policies. In the UK, some DCD hearts were procured by direct procurement, but these were excluded. This would have been the only center doing that. And then they used DBD, so donation from brain death cases, from each center during the same time period as the comparison group. This is how it worked. So the donor, they would withdraw life support, and then the donor would expire naturally. Once the blood pressure went below 50, this was considered this is the onset of the warm ischemic time. And then once there was asystole and no respirations, this is when death was decided to be time 0. 5 minutes of hands-off period were then there to confirm the death. Circulatory death was declared, and then it takes about 10 minutes beyond that to set up the ECMO and start reperfusing. A couple minutes of reperfusion, and then the heart begins to reanimate. And by 25 minutes after the administration of vasopressors, the heart is reanimated. ESMP versus cold storage. After the assessment and procurement, hearts are preserved during transportation using ESMP or CS. 19 out of the 21 cases preserved by SMP were from the Royal Papworth Hospital. Only 2 were from another hospital, University of Nebraska, in which the cold ischemic time was estimated to be very high. That's why they used the ESMP. ESMP Per protocol is used in the UK, an exception made for 4 cases in which the patient and donor were in the same hospital. So very short ischemic time, so ESMP wasn't deemed necessary. And then outside of of those institutions, all hearts from Spain, Belgium, and the remaining US hearts were preserved with cold storage, so on ice. The NRP protocol was the same between both groups. I think the only statistics that I think I really need to discuss are their survival models. They had one model that was unadjusted, so without potential confounders, and then another model where they adjusted for donor and recipient ages and also cold ischemic times. And this was because the 2 factors that reported to have the greatest impact on heart transplant survival are donor and recipient age and cold ischemic time. Everything else was pretty standard. All centers had ethical department approval. Data was collected anonymously, so informed consent was waived, and there was no funding source for the study. So now I'll talk about the results. These are the pre-transplant demographics. I'm highlighting here some important factors that may or may not be statistically significant. So you can see donor age was different between the 2 groups. NRP was average age of 32, DBD was 36. So, 10 years ago, I would have said that's a big difference, but now that doesn't seem like such a big difference. But this was statistically significant. The recipient age, it trended, but there was no statistically significant difference in age in the 2 groups. And cold ischemic time was actually lower in the NRP group, but pretty low in general. So the difference is not that significant. A couple other things. There were more females in the DBD group, although I'm not sure what the significance of that is. And then you can see that there was no difference in females in the recipient group. Interestingly, there's the same percentage of mechanical circulatory support after the transplant, but also interestingly is that in NRP, it was mainly, there was much more balloon pump usage. Whereas there was no VAD usage post-transplant, but in the DBD group, there 5% were put on a VAD afterwards. And then, as you can see, the 30-day survival, 1-year survival, and 5-year survival were the same in the NRP and DBD groups. One thing I'm just going to point out is in the text and in the supplemental data, these numbers were different than in the table. So you can see the difference right there. I don't know how to explain that. And then here is the Kaplan-Meier curve showing essentially similar survival between DBD and DCD using NRP. Then there's a table that lists some of the parameters for the NRP group. You can see we already talked about the donor age that was slightly different between the groups. They don't give us these parameters for the DBD group, so we don't know the height, weight, and ejection fraction. They also don't report what kind of pharmacological support that the DBD group had. The recipient age was the same in the 2 groups. These times don't really apply to DBD, and then they also don't report the pulmonary vascular resistance of the recipient and the cold ischemic times. Oh, sorry, the cold ischemic time they did. We said it was different, but it was pretty low in both groups. We talked about this, that the 30-day, 1-year, and 5-year survival were similar in the 2 groups. But all of this other information was not provided for the DBD group, so there's no comparison we can make. Regarding the 2 survival models, you can see that the question of donor age, we had a statistically significant difference in donor age in the 2 groups, but the hazard ratio was essentially 1, so that really probably didn't have any meaningful effect. And the same thing with donor sex. Even though there were more females in one group, the hazard ratio was essentially 1. And I should just point out that none of these hazard ratios had statistical significance. And then this is the sub-analysis, the cold storage versus ESMP. So you can see that the donor age was quite different. They were younger in the cold storage group. Oops. And then, sorry, also the use of an intra-aortic balloon pump was also different, with much more balloon pump usage in the ESMP group. You can see that the ICU stay was longer in the cold storage group, and but the ejection fraction was higher in the cold storage group, but not by much, so probably not a meaningful difference. The other thing that is interesting is that RV function in the short term and long term was better in the ESMP group, but these numbers are qualitative, and it was assessed differently at each center, so I'm not exactly sure how to interpret this. This is a list of the causes of death, and I think the only thing I'll point out is that there was more primary graft failure in the DBD group, and we can come back to that. So those are their data, those are their results, and now I can go through a summary. So DCD with NRP versus DBD, NRP demonstrated comparable overall survival to DBD. The rates of post-transplant mechanical circulatory support were the same, but an ECMO utilization was similar. NRP had a 4-fold higher rate of balloon pump use, and there wasn't any VAD use in the NRP group. And it's worth noting that an intra-aortic balloon pump is a lot cheaper than a VAD. None of the 14 deaths in the NRP group were from primary graft dysfunction versus 23% of deaths in the DBD group. But I think there probably is no significant difference. If there was a significant difference, you would expect the survival or MCS rates to be higher in the DBD group, and they weren't. So probably not a significant difference. Potential benefits of DCD, NRP versus DBD. NRP demonstrated increased survival at earlier follow-up time points. They were suggesting that it's possible that the NRP protects the DCD heart by minimizing ischemic time. NRP does protect the DCD heart by minimizing ischemic time, but DBD, of course, has no ischemic time between brain death and procurement. So what can explain this potential benefit? And there's a discussion about potentially there being a Cushing reflex caused by brainstem death that involves the release of catecholamines and may result in Takotsubo-like cardiomyopathy in the DBD group. But I don't know that. I think that's just conjecture. They do state that it's not possible to confidently claim that NRP offers superior survival. And I think that, and they acknowledge that this will require support from a randomized control trial. Cold storage versus machine perfusion. The sub-analysis of the NRP group showed no difference in overall survival between cold storage and ESMP, but ESMP had shorter ICU days despite having older patients, better RV function, but this, like I said, was defined differently by the different centers. And I think the big caveat here is that nearly all of the ESMP was performed from a single center, so center bias can't be excluded. The strengths of the paper is that this is the largest international multi-center observational study on NRP to date, with 157 cases. To put that in perspective, previous literature has come from 7 centers with a cumulative 53 cases being described. And that the gold standard DBD cohort was contemporaneous and from the same centers as the DCD. The weaknesses are that there's no comparison between NRP and direct procurement. The study is very prone to center bias. Nearly all of the ESMP preserved cases came from a single center. There are very few ESMP preserved cases in the cohort, so comparison between the ESMP and cold storage has to be qualified. And then the median follow-up time was relatively short. Censored events and transplant increase after the 3rd year, and they didn't really look beyond that. And the other thing is there was no analysis of pre-transplant use of mechanical circulatory support. They acknowledged that that data wasn't available. And then not being a randomized controlled trial, they can't exclude confounders. So survival rates of NRP, these are the conclusions that they came to, stated in the paper. Survival rates of NRP are comparable to DBD transplantation. They say we can reasonably conclude that NRP increases the donor pool significantly. And actually in the study sites, they increased their number of heart transplants during that period by 23%. And they state that increased acceptance and utilization of NRP for DCD heart retrieval will require studies demonstrating the absence of cerebral perfusion during NRP. So that made me stop and say, wait, what? There's actually a lot more to the story. And one thing is the ethical concerns of doing this in the first place. You can see that the American College of Physicians actually put out a statement regarding NRP. They described a proposed method of organ retrieval that uses what has been called normothermic regional perfusion, NRP, with controlled donation after circulatory determination of death, referred to as NRP-DCD, raises ethical questions and concerns. They say it raises profound ethical questions regarding the dead donor rule, and I'll talk about that, fundamental ethical obligations of respect, beneficence, justice, and the categorical imperative to never use one individual merely as a means to serve the ends of another, no matter how noble or good those ends may be. I think interestingly, they say that NRP is more accurately described as organ retrieval after cardiopulmonary arrest and the induction of brain death, and they recommend that use of NRP be paused. And I'll just note that in the UK, they're not using this this method anymore. So what are the ethical concerns? I'll break them down. One is that NRP does not conform to the US definition of death, which is that death is the irreversible cessation of circulatory or brain function. Because NRP restores circulation, the cessation of circulatory function was not irreversible, in fact. They say that NRP violates the dead donor rule, that donors cannot be made dead in order to obtain their organs, and organ retrieval cannot cause death. So if restoring circulation resuscitates the patient, then the intentional ligation of the arch vessels intentionally causes brain death. And then the other concern is that the intentional ligation of arch vessels to prevent brain flow may be incomplete, that there might be some circulation to the brain, either by collaterals or for some other method that could potentially restore some brain function and support consciousness. And I'll just mention that that last point is the specific reason why in the UK this is halted. They're going to perform studies measuring cerebral brain flow to try to demonstrate that it's not significant. So the first claim that the NRP does not conform to the US definition of death, a counterpoint is that the patient has already been declared dead after 5 minutes without circulatory function. That restarting the circulation is not for the purpose of resuscitating the patient, it's just for regional perfusion of the organs, and the patient's already dead. And it's established and agreed upon by the family that any efforts to resuscitate are futile and that the patient has no chance of a meaningful life. And these patients are evaluated for neurologic function, and it's decided that the anoxic brain injury is sufficient to make resuscitation futile. There's the statement that NRP violates the dead donor rule. Quite simply, the argument is that the patient has already been declared dead by a circulatory death and that you cannot die twice. And then the issue of NRP requiring the intentional ligation of arch vessels. DCD donors have many tests indicating severe brain damage. And after the 5-minute standoff time, it takes another 10 minutes to establish circulation. So now there's greater than 15 minutes of anoxia that precludes meaningful brain function. And I read one argument that the high intracranial pressure at this point will prevent collateral blood flow. So additional thoughts, direct procurement yields good results and is not controversial, so why not just use DPP? This was an argument made by, I believe, a Mass General surgeon. I mean, one, it's extremely expensive in comparison to NRP, and it doesn't allow for the preservation of other organs without additional organ-specific preservation devices. Why not monitor brain perfusion? That sounds simple, but it's very unclear how this is to be done effectively. Cerebral oximetry cannot entirely exclude blood flow, and even if what is your limit for the threshold of detection of blood flow, and what is adequate, what is sufficient? Those have to be worked out by the community. And as I mentioned, the UK has halted the practice of NRP until there are data that address the cerebral blood flow issue. So that was a shorter presentation than I anticipated, but I also want to provide some light reading. Of course, this is the study, and this is an interesting overview with interviews from various physicians who practice these methods or are concerned about them. And then this is the most outspoken, I think, against this method is this cardiologist here, and he has an interesting paper going through breaking down the ethical concerns one by one. So I think with that, I was hoping we could have a discussion about this. Does anybody have any thoughts or questions?
Thank you, Greg. This is very interesting topic. I'm pretty sure we have many comments from pathologists.
Mark, I see your hands up.
Yeah, Greg, great presentation, really interesting paper, and really thank you for bringing that to our attention. I don't think that's a paper I would have gone out and read on my own, so that was really interesting. The part you bring up at the end, I think, is really the most interesting part. It works, it would be beneficial, and now you just have to weigh the societal benefit to the individual benefit, and I think that's where medicine is often like, what is good at a societal level? If you can increase transplants by 20-something%, have good outcomes, save some money doing it as well, versus what do we consider a reasonable way of dying and how that works. So I really like how you brought that piece to the story. It's more of a comment than a question, but maybe you could opine more. I don't know if you have some ethics training in this area that you want to share with us.
I don't have any ethics training in this area, but this was brought to me during an ISHLT, International Society for Heart and Lung Transplantation sort of leadership meeting, and it's something that the surgeons are extremely passionate about. They really believe in this, at least in the ISHLT, they really believe in this as an important way of expanding the donor pool, and I think we have a lack of responses to that that ACP statement, and I think ISHLT for one probably needs to organize something. There is some statement, but it's a little bit weak. So I think that societies are going to have to speak up and express themselves, and otherwise I think it's going to be the loudest voice in the room that really determines what the practice is. But I think that the data they present are compelling to me. I think that it does seem like it's a surprise. Everybody thought that these DCD hearts, because they're of the ischemia, they wouldn't be as good as the DBD hearts, but it seems that they're able to do this effectively this way. Carmela.
So what other organs are retrieved using this technique other than heart? Because, you can work with other organizations to, have a stronger point of, having this kind of procurement.
Right. So I know that this is a technique that has been used for the liver, and I think before the heart, and liver and kidneys, basically. I'm not too up to date on the status of the lung, but I think this was not controversial when you were harvesting just the liver and the kidneys. It became controversial with this idea of resuscitation of the heart, because now it questions whether it reverses the declaration of death. So despite there being that concern about brain perfusion, that really wasn't something that was too controversial back then. But liver and kidneys is the answer to your question.
Can I ask a quick question, Greg? Thank you very much. I don't understand. There's like 15 minutes from the declaration of death and the resumption of circulation. During that period of time, couldn't there be some studies of neurological studies going on that would enhance the death proclamation?
Yeah, I mean that's the big argument, and there's an interesting discussion of that in that Medscape article, article I mentioned, because that's really what the goal is in the UK is right now, to establish that. But it's it's surprisingly difficult to come up with criteria that are, you know, what does your limit of detection has to be to ensure there's no flow, you know, and I think even, you know, the neurologists have already assessed the patient and made some determination. So maybe the definition of brain death has, and you know, the definition also depends on the location. Brain death is actually defined differently in different locations. So I think it sounds like it should be a simple problem, but it's actually quite difficult.
In the old days, we used to do EEGs all the time.
Yeah, I think the EEGs, they're
Before
talking
you
about
were born,
brainstem
Greg.
EEG also. Yeah. No, brainstem EEG was something that's discussed as well, but I think I think even without EEG activity, I'm not sure that you know, that's going to be acceptable to people. If you can establish some blood flow, maybe it's below the limit of detection.
All right, thank you.
It's a bit of a spiritual question, right?
Yeah.
So, Greg, what you're saying is that EEG is not good enough. Is that correct?
Well, I
According
think
to
that's
people?
it. I think it will depend who you ask, you know, what is good enough. But I mean, I think the studies now involve mainly measuring flow and, you know, correlating with oximetry and with EEG.
So a counterpoint is that, do you do that flow measurement in regular people you pronounce death?
No,
That's interesting.
no,
No.
no.
Right.
So you also give some economic point of view that it's very costly for some donation from a traditional way. In this new way, is that much cheaper compared to the traditional cost?
Well, the traditional, it's more expensive than the traditional cost if you consider the traditional cost to be donation after brain death, because you're adding the machinery and the work to cannulate the patients, you know, with ECMO and keep them on ECMO. So so that was estimated to be as low as $4,000, which surprised me. You know, the OCS, the heart in the box, is a relatively new thing. That is, you know, remarkably expensive and has a number of single-use parts. And you know, I think because they're not going to do that for all the different organs, you know, it limits what the donor is able to donate, only the heart. And I think that the issue of being able to assess the heart before procuring it is very interesting too, because for, you know, if 17% of the time you're going to throw away $100,000 worth of equipment and effort, that's not really acceptable. It might be acceptable at Mass General, but you know, but you know, transplantation is a worldwide thing, right? I mean,
Yeah,
so
yeah,
you have hospitals in other countries, you know, in South America, where you know, this is they don't spend the money like we do in the US on these things, you know, because we spend a lot of money on end of life care and this stuff, but they don't do that. So I think it's an interesting point too. I mean, perhaps you could make the argument that, you know, this sort of you know, heart in the box technology will become cheaper. Maybe that just you know, we need to wait for innovation in that department. But you know, I think the argument to the contrary is that this can just be, you know, you're not really animating you know, not really resuscitating the patient. You're simply using them to perfuse the region and the organs in the region. It's compelling.
So another point, you know, I doing this kind of animal research for a long time, we're always talking about reperfusion injury, right?
Mm.
So sounds like it's not a major factor here, or it's because the time period we monitor is not long enough to assess the damage.
Right. So I think this would be an interesting role for pathology. You know, if we're able to evaluate, you know, biopsies, first, second, third biopsies from these hearts, there's a whole, I think we could learn a lot, right? I mean, I don't know, maybe we will see more evidence of reperfusion injury. It seems as though from a outcomes perspective, this seems to work very well. So I imagine it's all the heart recovers function, after deemed suitable well enough. But I still think that there might be some differences that we will be able to see histologically, because I do imagine that the ischemia will manifest.
Yeah, that's just not to the level of damage to the whole heart.
Right. And perhaps we'll see that, most of it's, reversible injury and not irreversible injury.
Yeah.
To what degree do you assess the hearts prior to transplantation? I'm just wondering, because we published on a case where an individual with hypertrophic cardiomyopathy was transplanted into someone, and essentially years on, they died a sudden arrhythmic death from that.
Wow, that's very interesting. Yeah, and I don't really know, the paper doesn't go into how that assessment takes place. I imagine that it's going to be somewhat center specific and regional, but I think they do mention that this is done by transesophageal echo. So it seems that all of it seems like that's going to be the mainstay of how the evaluation is made. And I don't know what criteria they use in terms of suitability, but that probably needs to be standardized and worked out.
So, because obviously with circulatory death, it's there's a potential that you might have some underlying cardiac conditions as well.
Right. Yeah, and in these cases, I don't know. This was obviously not randomized. I'm not sure how they selected the patients, but there's also a concern that by that the people who die of a circulatory death, that it would be a different population than the patients who die of brain death, and so then you might be preying upon it could be a source of inequity in healthcare. But I think that needs more investigation too.
Absolutely.
More comments? Very good. If maybe we can discuss this point even offline. You may receive emails, why is this, why that, Greg? So
yeah,
I
think that some of this takes a little bit of digestion, to really think about it, and it's certainly something that I thought about a lot more than I thought I would. Just got back into my head over and over again after reading some of those concerns.
And some ethical issue, you better talk in a relatively quiet way, maybe.
Yeah, I think
Not in recording.
I would like to have seen some discussion, in the paper about that, but I felt that it was a bit lacking in that.
Yeah. So very good. Thank you so much, Greg.
I think we have one more question.
More
Yeah.
questions? Yes.
No. I wanted to thank you. It was extremely interesting, all these ethical aspects. In fact, I was a little bit surprised because I was thinking that we'll speak about heart transplantation and so on. I said, oh, it's not really my topic.
Right.
But in fact, it's very interesting. And we have in Switzerland also a lot of discussion about the definition of the death, brain death. As in forensic, we are confronted with donors frequently because we have to decide which organs can be taken, including the heart, because most of the donors are forensic cases, at least in our practice, because you have traumatic deaths, and so they're the best donors, I think so, also in US.
That's an interesting point. And actually, there's a distinction between controlled DCD and uncontrolled DCD. And I don't think I necessarily understand all the nuances of it, but I think those kinds of deaths, the traumatic ones, they were excluded. They weren't doing them that way. There had to be discussion with the family. There had to be discussion.
No, but we have it
with the patient too. The patient had.
But even today, I was asked by my colleague, do you think that they can take the heart or not, considering the story? I say, yeah, give it, because it's important.
Right.
So we have and we have also both techniques of how to take organs. Yeah.
Yeah,
We are
yeah,
confronted. We have to decide really which organs can be done given.
yeah. And I think, and there's also interesting constraints about how the conversations are had. You know, none of the anesthesiologists who are there can participate in the procurement process. They have to bring in a new crew. None of the transplant team can discuss this with the patient. Has to be discussed with the, you know, because of the perception of conflict of interest or potential for conflict of interest. And of course, discussion, explanation of the method needs to be discussed too in detail. And so they have a lot of ethical considerations that I didn't bring up.
Yeah, very interesting. Thank you.
Thank you.
I was wondering if there are any studies of the brain from all of these donors after a circulatory death, and if there's anything that could be gained from that.
Well, I know that's like, as I mentioned, in the UK, I think at the Royal Papworth Hospital, that's what they're pursuing right now, more studies on the brain, and with particular regard to flow, and what flow, you know, return of flow establishes, and how do you confirm there's no collateral flow. I thought the intracranial pressure argument, it was a little bit of hand waving, but you know, maybe someone who understands the fluid dynamics better than I do can attest to that.
Oh, more questions? Comments? Congratulations to Greg.
Well, my apologies for making it a bit too short. I think I went through kind of fast, and I thought it would be something that would generate a lot of discussion. So I wanted to make sure I left time.
Yeah.
Thank you for giving us our time back, Greg. It's okay.
All right.
Thank you.
All right.
Thank you.
Thank you very
Thank you.
much.